right, good morning, everyone. My name is Gaurav Lakhanpal. I'll be presenting a follow-up on my previous talk, which is about the update on pelvic venous disorders. Today's presentation is going to be on how should patients with symptomatic pelvic venous insufficiency be treated. As with all medical problems.
So, Gaurav,
yeah, can you hear me?
I just wanted to say a couple things. I know you want to just
Oh,
you want
sorry.
to fly under the radar screen, but I think it's important to introduce you the proper way. So, and this is Rick Kennedy from the Center for Vascular Medicine. Dr. Nguyen asked me to take a moment and introduce Dr. Lakhanpal formally this morning. So, Dr. Gaurav Lakhanpal, as everyone knows, is at the Center for Vascular Medicine full time, and especially in the field of pelvic venous insufficiency, as in his specialty of interventional cardiology, he's become quite well known for not only being a very high volume operator and but then also someone who's very much a thought leader nationally and internationally in this disease state. So we're very lucky to have him both at CVM and at SAR. And the only thing else I'll say, other than I'm excited for obstruction as well, is that anybody for the fellows at CVR, anybody at CVM, you should consider as a colleague and as a resource. And anytime you have any questions, whether they be about any one of us is more than happy to help and to consult and to assist in any way we can. So please feel free to reach out. Gaurav, I will tell you, is one of the best teachers that I've ever had. So I'm excited again to have him this morning. And if you would all please welcome him. Thank you.
Oh, thank you, Rick. That was very kind. So as with any medical issues that we have in life, there's always a medical part of the treatment, and then there is the interventions. So a little bit about the medical therapy, which is not very robust when it comes to treating patients with pelvic venous insufficiency, but has included psychotherapy, use of psychotropic drugs, use of gabapentin and amitriptyline. For the longest time, these disorders were associated with psychosis and psychotic issues. And for the longest time, people thought that this was all in the minds of the patients, so they would treat them with these medicines. Analgesics and non-steroidal anti-inflammatory drugs, these are basically to relieve the pain associated with the pelvic venous hypertension. Dihydroergotamine has been tried as a vasoconstrictor. Progestins, which is contraceptives, hormone replacement therapy, danazol, and of course, recently gonadotropin-releasing hormone agonists, of which Orilissa is an example, which was approved, I think, about 3 years ago by FDA for treatment of endometriosis-related dyspareunia and dyspareunia itself. Not very effective, so it's not a blockbuster medicine, but has been tried and people keep using it. I've had a few patients who've not had relief. They have been put on this by their pelvic pain specialists. The only caveat is that it does cause bone loss, so it has to be, the therapy has to be designed for a short, not for a long period of time. They cannot be taken for a long period of time, and the dose has to be adjusted based on that. Venoactive drugs, which have been very popular, and we'll talk a little more about that. So again, how hormonal therapy has been shown to be, it relieves symptoms in approximately 40% of patients, in a combination of medroxyprogesterone acetate and psychotherapy. It may be effective in about 60% of the patients. So the venoactive drugs, of which we know Vasculera is the one, which is the branded medicine. The diosmin complex, which is available, is a micronized purified flavonoid fraction extract, and they have a protective and a tonic effect on the venous and capillary wall. So this increases the venous tone, which again relaxes these veins and prevents pooling. And so, I mean, that's the mechanism, but how they actually work, that nobody really knows. There's only one trial which was performed in Russia by Gavrilov and his partners in 2016, in which they gave 1,000 milligrams a day of MPFF extract to women who were suffering from chronic pelvic pain associated with pelvic varicose veins. And at 8 weeks, they showed a continuous decrease in pain, and the symptoms completely disappeared at 14 weeks. Has not been replicated by anywhere else. There have not been many trials, maybe something to look at here. But again, because it's a very expensive drug, it's a branded medicine, and a lot of the people are not able to afford it. And because it's available at 630 milligrams here, so the initial dose would be 630 twice a day if you had to see any kind of significant improvement in symptoms, or give the drug a chance to actually work, and has to be taken for 3 months before you can make a decision one way or the other. We do use it in patients who we've tried everything else, including intervention and all that stuff, and they still don't get better. So that's an option that we have. The clinical effect of this medicine persists for a long time in this trial, 6 to 9 months, with stabilization of the disease course. But as I said, has not been replicated since then in any other trials or studies. The surgical treatment was always an option. There was, once they started identifying these people with ovarian vein reflux, ovarian vein ligation was presented in the 1980s as an alternative to patients who had this problem, laparoscopically done, formed supine with CO2 pneumoperitoneum. It had some shortcomings. It induced venous decompression because of the use of CO2, that led to underestimation of the number of varices and hence under treatment. Also was more invasive, required general anesthesia, so morbidity associated with that, and there was only a small case series that were reported. Hysterectomy has been the go-to for pretty much anything that they cannot explain from a gynecologic standpoint, if it's bleeding, fibroids, and has been tried for people who have had chronic pelvic pain. And we've had patients who've had mixed results. A few of them, maybe like about 30%, have had complete relief with hysterectomy. The remainder, I mean, I'm talking about my personal practice and CVM's, I think, overall experience. We still see a lot of patients who had hysterectomy with poor pelvic pain, and they come back still with significant symptoms. So studies reported residual pelvic pain in a third of the patients treated with hysterectomy and recurrence of pain in 20%. I mean, our numbers may be 50% patients to have improvement and 50% still have persistence of symptoms. So coming to what's in vogue and what is being used pretty much throughout the world as first-line therapy for people who have pelvic venous insufficiency related to refluxing veins or incompetent ovarian and periuterine veins. Transcatheter embolization, which was the first case, was reported in 1993 by Edwards et al. He's an interventional radiologist. And what they basically inserted was coils in these veins. So basically, once you identify pathologically dilated axes with retrograde flow, these are occluded mechanically. And there's a variety of mechanical devices, including coils, which are used, and this can be used with or without sclerotherapy. And also now glue has been reported to be used in literature to close these veins. It is the best way to do it is using the sandwich technique, which combines these metallic devices with the 2% foam, could be ethoxysclerol or polydocanol, which is prepared according to Tessari's method during the procedure. The recovery is pretty okay. I mean, some people will have pain during the recovery, which is managed with NSAIDs. This is just a depiction of how this procedure is done. On the left of your screen, you see chemical embolization of the right ovarian vein, where the catheter is coming from the jugular vein and it's selectively cannulating the right ovarian vein, and then you inject the foam and done in a reverse Trendelenburg position. On the right side, you see cross embolization of the right ovarian vein from the left ovarian vein. So in panel A, you can see the catheter, which is going into the left ovarian vein and going through the transpelvic collaterals, going up to the right ovarian vein. And on the B panel, you can see the catheter coming into the right ovarian vein and then going into the left ovarian vein, where you start seeing the coils being deployed. So they induce a lot of thrombotic and inflammatory response in these refluxing veins and ultimately shut them down. So the premises is, again, basis of these treatments is based upon what you understand about the disease process. So people who believe that reflux is the reason behind the discomfort will close the veins. It's like in the superficial system, you do use different modalities to close the refluxing veins. The same thing being used in the ovarian and periuterine veins. But if you feel the compressive pathology is the one which is causing the patient's symptoms, then you open the deep system. So we'll talk about that. So vulvar varices, again, this example of what people undergo with the chemical and coil embolization. This patient has a bunch of pelvic varicosities and vulvar varices, and all these escape veins which are being shut by multiple coils and foam injected. So this was a meta-analysis published by Meisner and Gibson in phlebology, where they looked at various studies, the treatments done, what was treated. Was it the right ovarian, the left ovarian, bilateral ovarian, and then of course the branches which arise from the refluxing veins which arise from the internal iliacs, and the various modalities use coils only, sclero plus coils, glue and coils, glue only. And in their analysis, they found there was complete or partial improvement in 68 to 100% of the patients. And if they looked at visual analog pain scores, the improvement was remarkably consistent across all these studies. So switching gears a little bit, we start looking at the compressive pathologies as the cause of pelvic venous insufficiency. And the first study actually to demonstrate that was out of Tennessee with Dr. Doherty's group, Stephen Doherty, in 2015. He published a small study of 19 patients who had presented with dominant pelvic symptoms, and they were, however, treated only with stents for a non-thrombotic venous outflow obstruction. And these patients were followed up for a mean of 11 months. And 15 of the 19 patients had complete resolution of pelvic pain. 14 of the 17 sexually active patients had complete resolution of dyspareunia. And 13 of 15 patients who had concomitant lower extremity pain and edema before the treatment had complete resolution after the stenting procedure alone. So although these patients did demonstrate a dilated ovarian vein with reflux and periuterine vein with reflux, they were treated only with, and as well as compression of their outflow, left common iliac vein was most commonly treated. And they were treated only with stents and had significant improvement in a significant number of patients. So the conclusion of this study, although it was small, only 19 patients, but it did make a small impact, and it gave us a little more grounds of what happened next. I will share with you. So the conclusion of this study was non-thrombotic obstruction of the left CIV or IVC is an unappreciated cause of pelvic congestion syndrome. Angioplasty, venous angioplasty and stenting, they provide excellent short-term results with resolution of chronic pelvic pain and dyspareunia, and hence venous obstruction should be considered and carefully evaluated in patients presenting with pelvic congestion, and the treatment of obstruction alone may solve the patient's problems. So about the same time, we had started looking at our data retrospectively to see what was what we found led to the publication of this paper in 2017, 2018, which is iliac vein stenosis is an underdiagnosed cause of pelvic venous insufficiency. So basically, this was the demographics, average age. I mean, let me show you so it was a retrospective chart review of about 220 women who underwent 227 procedures between January 2012 to September 2015. All of these patients had a complete gynecologic evaluation. as well as a pre-op lower extremity and ovarian vein duplex procedure, duplex scan done prior to any intervention procedures. They had pre and post procedure visual analog pain scores recorded. And majority of the patients with ovarian vein reflux and obstructive lesions were treated with stage procedures, meaning embolization followed by stenting. And then a subset of patients were treated with simultaneous embolization and stenting. So this was the demographics. Average age was about 45. Average number of pregnancies was 3.5. And then these were the concomitant gynecologic disorders, but these had all been addressed or found to be not significant, causing the patient's symptoms. So this is a breakdown of the pre-pain and the pre-procedure and the post-procedure pain scores. Patients who underwent embolization alone had a pre-procedure score of 7.41 and went down to 3.15. Patients who had embolization plus stenting had a pre-procedure pain score of 8.62, improved to 1.63, and stenting alone had a pre-procedure pain score improvement from 8.78 to 1.42. So it was all statistically significant across the board. So this, in this subgroup, 88 patients received ovarian vein embolization followed by stenting, and 39 had simultaneous embolization and stenting. Only 9 of these patients reported improvement after embolization. So our protocol used to be to have the patient, of course, with the initial consultation, get a complete scan, identify the refluxing ovarian vein, the periuterine veins, and if there was symptomatic enough causing lifestyle limiting, issues, the patient would be scheduled for a venogram. We would do a complete study, including the documenting of the ovarian and the periuterine vein reflux. And then we would treat them with chemical embolization at that time, and then have them come back in a week or 2 weeks to assess the outcomes of that. And as this study found out, less than 10% of these patients had improvement in symptoms after embolization. So the protocol became to simultaneously schedule them for a stent procedure in a couple of weeks post the embolization procedure. And I can remember from the top of my head, of all the patients that we did it this way, I had only 3 patients who did not require a stenting procedure, had good relief from embolization alone. But in any case, this study showed that embolization, simultaneous group of the embolization plus stenting versus a stage group, there was slight improvement in the pain scores in the stage group, suggesting that the pelvic reservoir treatment may have some role in contributing to the pelvic pain in these patients. So the study led to the hypothesis that stenting alone works. So women with combined iliac vein outflow obstruction and ovarian vein reflux will demonstrate improvement in visual analog pain scores with venous stenting alone. So this was the basis of our second study, which I will present in I want to show a few cases. So this led to a practice change in Center for Vascular Medicine after 2018. At least in my practice, I would document reflux in the ovarian vein, but I would not treat it. I would just do the intravascular ultrasound, and if that showed significant compression, we would stent the patient. So this was a 37-year-old female, gravidas 6, para 6, presented with pelvic pain, dyspareunia, dysmenorrhea, and labial varicosity. You can see on the left of your screen is the iliocaval venogram. On the right side is a selective canalization of the ovarian vein, and then you can see the dilated ovarian vein with reflux. It's a little confounding with the underlying bowel gas, but if you see, if you watch it carefully, you'll see that. And then there's crossover happening in the pelvic cavity over there, and a little pooling happening. So if you stay on the floor long enough and you inject more amounts of dye, you would see the crossover onto the right side. So this patient then underwent an intravascular ultrasound, which was our protocol. It has been our protocol. We do all procedures are done under intravascular ultrasound guidance. So, and had a 60% compression in the left common iliac vein, which was then stented with a 16 millimeter by 120 millimeter barred Venovo stent. So 16 millimeter is the diameter of the stent and 120 millimeters is the length of the stent. And you can see that venogram on the left side showing the stent, and then the IVUS on the right post-stent placement. So at last follow-up, this patient's pelvic pain score, that was a maximum of 8 pre-procedure, went down to 0 and continues to be so. With the second patient, there's again a 37-year-old female, gravida 5, para 3, presented with pelvic pain, dyspareunia, dysmenorrhea, vulvar varices, and recurrent superficial venous insufficiency, which was happening since 2018. So she was sent to us in 2020. You can see some hardware in the back. She had a fall, traumatic injury to the back when she was a teenager and undergone placement of these of the hardware. So her venogram, iliocaval venogram on the left, and you can see is a reflux in the left internal iliac vein. If you focus on it, then you can see that late, once the perivenous cava and the left iliac vein clears out, you can see the filling of the left hypogastric vein. Then the selective catheterization of the left ovarian vein shows dilated left ovarian vein with reflux, as well as pooling in this left-sided periuterine veins. So she also underwent an intravascular ultrasound, which showed a 84% compression in a left iliac vein, which was then stented with a 14 millimeter by 160 millimeter broad venover stent. And this was a venogram post-procedure on the left, showing the stent, and then the IVUS on the right after the stent was placed. So again, her pre-procedure pain score went down from 7 to 0. So I included this to show that, people do have had embolizations done at outside places, and they still have recurrence of symptoms or persistence of symptoms. So this lady was again 37, gravida 5, para 4, presented with pelvic pain, dyspareunia, dysmenorrhea, recurrent superficial venous insufficiency, which is ongoing for 10 years. So her initial consultation was done via tele because she lived in Virginia Beach. And at that time, she did not disclose that she had had any coiling done. So and we had no idea that she had coils put in. And when she came for the procedure, when we did the fluoroscopy and we see this, then post-procedure we asked her, and then she kind of remembered vaguely that 10 years ago in 2010, she had been treated for pelvic pain with some procedure done at some military hospital or something, because her husband was in the armed forces. So. But she said, but it never made any difference. So anyway, so she underwent intravascular ultrasound, showed a 91% compression in a left common iliac vein, successfully stented with a 16 by 160 millimeter stent. And scores went down from 8 to 0. Again, you can see the stent on the left side, venographically, and then the IVUS on the right, post-procedure. So, as I said, our initial study had given us the grounds for our subsequent publication, and then the protocols that we followed give us the patient volume or patient population. And we presented this paper in 2021, was published in Journal of Vascular Surgery, Venous and Lymphatic Disorders, titled Pelvic Venous Insufficiency Secondary to Iliac Vein Stenosis and Ovarian Vein Reflux, treated with iliac vein stenting alone. So we looked at 82 patients retrospectively, and of these, 38 had a 6 months or more follow-up, and hence they were included in the analysis. So these were, again, women who presented with pelvic pain secondary to combined iliac vein stenosis and ovarian vein reflux, however, were treated with stenting alone. And the pre-procedure evaluation consisted of evaluation by a gynecologist to make sure there was nothing GYN related causing the patient's symptoms, pre-procedure, and 6-month post-procedure visual analog pain scores. So our go-to method of evaluating for symptom improvement has been visual analog pain scores. Then all of these patients had pretty much had a transabdominal duplex ultrasound pre-procedure to look for iliac vein compression, to look for dilated ovarian veins, and to look for any reflux in the periuterine veins. We also documented the stent type, the diameter, the length, as well as ovarian vein diameters. So all these patients who qualified met the criteria based upon their symptoms, underwent diagnostic venography of their pelvic veins, the left ovarian vein, the reservoir, pelvic reservoir, as well as the intravascular ultrasound or IVUS of their iliac veins. We did assess the ovarian vein diameters intraoperatively by venography. And just for clarification, pelvic reservoir was defined as presence of 3 or more identifiable pelvic venous segments with or without cross pelvic collaterals. So this was the demographics of this study. 53% of these patients were Caucasian, average age about 47, gravidas status was 2.5 pregnancies, and they did have some comorbidities in the form of diabetes, hypertension, coronary artery disease was only 3%, hyperlipidemia, osteoarthritis, and some kind of cancers. And then the gynecologic comorbidities, endometriosis, fibroids, and ovarian cysts, all of these had been looked at, evaluated, and treated, or evaluated and not found to be significant for the symptoms these patients had. So this was the results of the pre and post procedure visual analog pain scores. Pelvic pain, non-cyclic, as well as dysmenorrhea was clubbed together with pre-procedure score of 6.86 and post-procedure up to the stenting went down to 1.7. Pelvic pain with dyspareunia, pre-procedure pain score was 4.3, improved to 0.41. The average area reduction by IVUS was 74%, so pretty significant. The average ovarian vein diameter was 6.6. So anything considered, anything 6 millimeters or more is considered a sign of refluxing ovarian vein or dilated ovarian vein that can contribute to patient symptoms. The stent location was in the left side in 32. So that's what we see. This condition is 5 times more commonly seen on the left than the right, although we do see a fair amount of right-sided compression too. The majority of the stent types were wall stents, 27, and 11 were Venous stents. Now, interestingly, a pelvic reservoir was present in 44% of the patients. Of these, 35% were partial responders, 6% had no response, and 59% were asymptomatic. And then the re-intervention rate was 18%. 7 of the 38 patients required a re-intervention, and there's a breakdown of that in the subsequent slides. So as far as the patients who presented with persistent symptoms, out of 38, 9 had persistent symptoms. So 29 had improvement. The presenting complaint out of those 9 patients was dysmenorrhea. So that's what and dysmenorrhea is probably, multifactorial, hormonal, etc. So, and of these patients, 8 patients who had presented with dysmenorrhea as the presenting complaint, 6 patients had no improvement, and 2 patients had partial improvement. And 1 of them had a presenting complaint of dyspareunia and had a partial improvement with this procedure. 7 of these 9 patients did have a pelvic reservoir, and 1 of these patients did undergo an ovarian vein embolization, but there was still no improvement and was subsequently found to have a labral tear, which was successfully treated with orthopedics. So this was the indications for the re-intervention in this study. We had 7 patients who required re-intervention. Most of the re-intervention was done for either recurrence of symptoms or contralateral symptoms. As you can see, so there were 4 contralateral stents which were put in for new symptoms. There were 2 patients who required stent extensions for recurrence of symptom, and 1 patient did undergo ovarian vein embolization, but again did not have symptom relief and was subsequently referred to orthopedics and had a repair of the labral tear with relief of symptoms. So based on this, our conclusion was that majority of the women with the pelvic venous insufficiency secondary to combined iliac vein stenosis and ovarian vein reflux demonstrated complete resolution of the symptoms with iliac vein stenting alone. So I think it was about 78 or 79% of these patients had complete resolution. All this was, again, a small cohort because of the abbreviated follow-up that we could see. I mean, only 38 qualified based on a 6-month follow-up. 8 of the 9 partial responses after stenting was primarily observed in women whose primary complaint was dysmenorrhea. So again, something to think about, when these patients come with dysmenorrhea, whether this is actually going to help them or not. And if that's the only primary complaint, we tell the patients that we are not sure this is the thing, the way to go. So of these patients, 7 did have a pelvic reservoir. So people who have a pelvic reservoir and who had incomplete resolution, our conclusion was that they should proceed with ovarian vein embolization. So iliac vein stenosis in women with combined iliac vein occlusive disease and ovarian vein reflux. So is the primary etiologic cause of pelvic pain in this patient cohort. So iliac vein stenting alone should be performed as the primary therapy in this group, and ovarian vein embolization should be reserved for women with a pelvic reservoir and a partial response to stenting alone. So that was the conclusion, and that's what the protocols that we've been following, and it kind of reinforced what we've been doing. Now we have a recent submission to AVLS and the UIP. We have, which is titled Long-Term Follow-Up for the Treatment of Symptomatic Pelvic Venous Insufficiency Secondary to Combined Iliac Vein Stenosis and Ovarian Vein Reflux treated with iliac vein stenting alone. So basically, the previous study that we had published was a 6-month follow-up. This is a 12-month follow-up of about 141 patients. And the abstract submission has been done, and we've found significant, it's kind of reproduce the results we did from the shorter term, the smaller study. We were able to do that in this bigger study with longer follow-up. The pre-pain scores improved from 6.6 to about 1.6, and average follow-up has been 12 months plus minus 24. So about 141 patients were looked at. Now, the only thing that we did different in this study compared to the previous study was we discounted patients with dysmenorrhea. So pain and cramping during cyclical pain, we discounted that. We did not count those patients. And also patients who presented with leg symptoms, we did not count those patients. So this is essentially pure pelvic pain, non-cyclic, as well as dyspareunia. So those are the patients that were looked at. And as I said, the results are pretty promising. So before I end, I wanted to show this. This is from Dr. Papa's archives. Another cause of pelvic venous insufficiency causing pelvic pain as a part of the compressive pathology is nutcracker syndrome, as we all, we talked about in the previous talk. It's the compression of the left renal vein by the superior mesenteric artery and the aorta. So this is a diagnostic venogram of a patient who presented with pelvic pain. You can see the selective cannulation of the left renal vein, and then this filling up of the, so let's go back. But anyways, this is the dilated ovarian vein with, a lot of filling of the periuterine veins, transpelvic collaterals. A significant pelvic reservoir exists, and you can see actually the antegrade filling of the left ovarian vein, of the right ovarian vein too, by contrast injection to the left ovarian vein. And then the previous angiogram or venogram showed the left renal vein. So this catheter is selectively cannulated into the left renal vein, and then the smaller catheter through that extends down into the left ovarian vein. So the patient underwent coil embolization of the left ovarian vein. You can see that the coils being deployed. And then the patient also underwent a assessment of the left renal vein ostium. And there was compression of the left renal vein based on that. And pressure-wise, if we remember the last lecture, greater than 3 millimeters of mercury, pressure difference between the pre and the post stenotic segment is considered significant. And so this patient underwent a Walston deployment in the left renal vein. You can see the completion venogram on the right side. So it's technically quite challenging to stent the left renal vein because you have to, because the compression is most commonly seen at the ostium of the left renal vein from the inferior vena cava, and in order to cover that, you have to project some part of the struts into the inferior vena cava. So there have been instances where there have been stent migration to the right heart. So it's not very commonly done. These procedures are done in tertiary care centers or in the expert hands like Dr. Pappas. He used to do a lot of vascular interventions when in his heyday, but he, of course, he continues to do that now, but has shifted his focus to venous disease, essentially superficial veins, and then deep stenting. So this, I think he was done when he was in the hospital setting. So we do not really do this in the outpatient setting, although I guess it can be done. The only thing is you just have to consider the risk of stent migrating to the right heart and be prepared to deal with that. So there's a lot of renal vein transposition which has been done for people who have nutcracker syndrome. Those are very morbid procedures. Locally here in the Mercy Hospital, there's a physician who does a fair amount of those. But I am not sure what the outcomes have been with the resolution of symptoms is concerned. So we've had patients who've had nutcracker plus May-Turner, and we've treated only the May-Turner or the iliac vein compression. And we've had great results and almost negligible symptom persistence after that. So in conclusion, when appropriately evaluated, most patients with pelvic congestion syndrome do have iliac vein stenosis. Now, of course, commonly known as May-Turner. May-Turner is basically compression of the left common iliac vein by the right common iliac artery. So that one point of compression, if you do have that, then that's considered as May-Turner syndrome. But there are various multiple areas of compression that we see in the mid part. Sometimes people will have it in the mid part of the common iliac vein, at the distal part of the common iliac vein. The external iliac vein may be compressed. If you compare it to the common femoral vein, you will see that's significant narrowing of the external iliac vein with the dilated common femoral vein. So those are the things that we look at with the IVUS, and we just call it iliac vein compression syndrome. So treating the stenosis without embolization of the refluxing veins will lead to better outcomes for pelvic and associated symptoms of dyspareunia or lower extremity symptoms. Short-term results are clearly better, but we have a study now with long-term intermediate, I would say a year, and then long-term results. We will continue to follow these patients and see if we have a 3-year follow-up and are able to still reproduce those symptoms. So the traditional methods, as mentioned here, have been embolization, and they still continue to be the norm outside of our practice, especially interventional radiology, will still continue to treat the refluxing veins with coils and foam, and then if the symptoms persist, then the consideration is made for a compressive pathology, to look for a compressive pathology and treat that. In our practice, it's the other way around. We treat the compressive pathology first, and if the symptoms persist, then we can consider embolization. Although I will tell you from experience that we see a fair amount of pelvic pain patients, and if those small cohort of patients who do not improve after stenting will not improve after embolization. I mean, there is a multitude of other organ involvement going on. It's a lot of nerve-related stuff, pelvic floor muscles, and this is just out of experience, not because we've been doing this practice and I'm professing that, but it's just out of, when you see a patient who's had symptoms from very young age and goes to see a urogynecologist and pelvic floor therapist, and then they finally get sent to you, and you tell them that, listen, we don't really think, I mean, we can do the procedure, but I don't know how much improvement it can be. And of course, they're desperate and they will get it done, but these kind of patients will not really have any significant relief from even from stenting. So they've had embolizations, they have stenting, they have hysterectomies, they have oophorectomies, they do Botox injections in their pelvic floor muscles, pelvic physical therapy, We have stent, what do you call implant, stent, what do you call the stimulus implantation, you know, these nerve stimulators, pudendal nerve blocks, everything possible under the sun has been done, but they still persist with symptoms. So those are the most complicated patients who you try to get as comfortable as possible, but you know, nothing really works for them. But that's just a small subset of patients. All right, so we'll stop here and take questions.
Yeah, Dr.
Hello.
L, can I ask a question? Hello.
Yeah, sure. All right. Hello.
Hi there. So this is great information. Do you find that BMI has an impact on how much these patients improve afterward?
That's very interesting. So, I guess you can say, I mean, I've less BMI patients will have less improvement. Let me put it that way. I mean, this is again, I'm looking back and thinking about these patients that I've been treating. The more heavier set patients somehow have had, I think we have had better results with improvement in their pelvic symptoms, and the skinnier patients are the one who continue to persist with these symptoms. And Rick, if you're there, can you back me up on that, because you see a lot of follow-ups too.
Yeah, I think it's very true. I think the post-procedure recovery is a little bit easier with patients with higher BMI, especially female patients. And then long-term, the back discomfort seems like it lingers longer in the lower BMI patients. I completely agree.
Isn't that interesting? Okay. And then my last question or comment is there a way to share this with the GYN world so that maybe a mixed approach or combination approach could better help patients?
The strategy for the paper that Gaurav spoke about that's going to be presented in fall in AVLS UIP
I lost you, Rick.
That's how we're
I lost you, Rick.
You got cut off, Rick.
Oh, I'm sorry. I was saying that the strategy for Gaurav's paper that he spoke about and for AVLS UIP is actually to publish in Green Book rather than Journal of Vascular Surgery to achieve that means, Teresa. You guys heard me?
Excellent. Yeah, that's great. Because I think that's going to benefit more folks, and give people at least a better algorithm to follow when they're looking at pelvic pain.
Gaurav, can I ask you a question?
Yes, sir.
This is something maybe not common and maybe even stupidly esoteric. With all the venous stents we are putting and everybody is putting, have there been anything that has been reported or anything of its effect on the arterial system?
That's interesting. No, we haven't really seen that. No, nothing has been reported. Nothing has, the best way to do would be to do simultaneous access into the vein and the artery, and then do simultaneous IVUS, and then of course you do an IVUS in the arterial system too after you do the stent in the venous system to see what's the impact on that left the right common iliac artery. But
in fact, there is an easier way, because a long time when I was looking at when we did AV fistulas and things like that, to see the effect of the shunt on the arterial system, we don't even really to have an imaging. If we could just have, for example, a pulse volume recording or ankle-brachial indexes before and after, and then see if there is any slight change. This might be temporarily occurring, because I know in AV fistulas, the changes were very significant in the immediate post-operative period, but the arterial system compensated, and within a couple of weeks, this was disappearing. So it has just been in my mind, and I thought I will ask you, because I really haven't seen any reports. So
no. So it's actually have been the other way around. Since you mentioned it, I recollected a couple of patients.
The other way is true, correct? Arterial stenting affecting the vein, correct? Yeah.
Yeah, we had two patients who had iliac artery stenting done. I mean, not close by; they were like far apart. But they started having left leg symptoms, swelling and heaviness after that. So which was very interesting. And we, of course, ultimately ended up IVUSing the iliac vein and was compressed.
That's
So-
very true.
So I don't know, it was iatrogenic or what, we've never had, but it's, I said, I just remember 2 patients who had this issue. It was a iliac artery obstruction and we stented it, and then the patient started having left leg swelling and discomfort and heaviness. And of course, the arterial system was wide open. It was the venous compression that we saw.
Thank you. All right, Rick.
Any other questions for Dr. Lakhanpal? You're done, Gaurav. Thank you very much.
All right, thank
Thank
you.
you, everybody.
Have a
Thank
good
you,
day. Yeah,
Gaurav.
thanks. Thank you, sir.
Have a good day, everyone.
Yeah.